Recording. I'm pretty sure I've met everybody at this point, but people kind of start in the pharmacy all the time. So just in case anybody doesn't know who I am, my name is Tyler Maxwell. I'm one of the PGY1 pharmacy residents here at Stony Brook University. Today, we're going to be looking at two different articles. These articles are both related to the treatment of hydroxychloroquine and azithromycin, or with or without azithromycin for COVID patients. The first one is the French study that has gained a lot of publicity, as being almost the founder study for hydroxychloroquine and azithromycin. And the next study we're going to look at came out a little more recently. It has not been peer-reviewed yet, but I noticed it this Monday. And it is looking at more of the clinical outcomes of using hydroxychloroquine in this patient population. Once again, if you're new to using Zoom, there is a chat option. I believe it mutes everybody as they come in, but feel free to use the chat. I've got my chat open and I'll try and pay attention to that. If there's any questions or anything, feel free to ask that. Likewise, if you have any technical difficulties, please let me know. I am also new to Zoom, but I will do my best to figure that out as they come up. This meeting is going to be recorded as well. We haven't quite figured out how we're going to distribute that yet, but for anybody that may not have been able to make this meeting, say in the main right now, if they're on breaks or maybe the opposite, they're having to work in the main, feel free to let everyone know that we are recording this, and we'll try and get that out as soon as we figure out the best way to do so. Okay, so we'll jump in here with our first article. So the first article is the French study. This is the one that had about 26 patients, and they evaluated the use of hydroxychloroquine and azithromycin in tandem for COVID-19 patients. This was an open-label, non-randomized clinical trial. And just a little background on COVID, a little bit of information on the virus. So in 2019, the virus likely emerged from Wuhan, China. This coronavirus is a little bit special because it went through an antigenic shift, meaning that humans did not have antibodies to this specific virus before the creation of this coronavirus. Coronaviruses are a single-strand positive sense RNA virus, and they're known to infect humans pretty commonly. A lot of them cause actually more symptoms of a common cold. But when this one went through antigenic shift, the combination of no previous immunity with the fact that this virus can actually be transmitted before the development of symptoms meant that this virus quickly went across 180 different countries worldwide. The virus does have an estimated mortality rate that ranges from under 1% to 27%. This is going to depend on what age you are, and as you increase in age, your mortality rate does increase as well. So in both the MERS in 2012 and SARS in 2002 infections, there was a higher mortality rate associated with those infections. But unfortunately, the SARS-CoV-2 virus that we have right now is much more infectious. We have a problem with just spreading the virus before it does cause too much damage. So as of yesterday, when I did take a look, nearly 50,000 people have passed away from this disease, and there have been nearly 1 million cases that have been confirmed worldwide. So infected patients are typically going to present with a shortness of breath, a dry cough, symptoms of an upper or lower respiratory tract infection. This could be like a rhinitis or a bronchitis and pneumonia. As the disease progresses, you may notice bilateral ground glass opacities on the chest x-ray, accompanied by increased oxygen requirements and elevations in D-dimer, CRP, and decreases in white blood cell. The percentage of patients that are hospitalized, again, has a range depending on age. It's about 2 to 3% of patients that are under 20 years old, and it increases to over 30% for adults that are over 85 years of age. When patients do succumb to this disease, it's often through the development of ARDS and or a cytokine storm. These will contribute to the breakdown of the alveolar sacs in the lungs, preventing patients from oxygenation. So due to the outbreak of this disease and how fast it has spread throughout the world, it's really important that we come up with some kind of a treatment option for our patients. So before we get started on this specific journal, I think there is some previous literature that does help shed some light on why hydroxychloroquine was an option in the first place and why we are studying this. The first study I'd like to look at is the repurposing of clinically developed drugs for the treatment of Middle Eastern respiratory syndrome coronavirus infection. So, as I mentioned, there were two coronavirus outbreaks in the past. There was one in 2012 and one in 2002. MERS was in 2012, SARS in 2002. And so in 2012, when MERS hit, a lot of scientists thought we need to come up with something to fight coronaviruses in case something like this does happen again. So they actually studied about 290 compounds against the MERS and the original SARS virus, and found some antiviral activity with compounds such as chloroquine and hydroxychloroquine. This original study was actually what showed hydroxychloroquine did have in vitro activity against the previous coronavirus outbreak strains. It is about 70% like the original SARS virus. And so there was a thought that it might work in this virus as well. Then the next study that came out was the in vitro antiviral activity of hydroxychloroquine for the treatment of SARS coronavirus 2, and that's this current infection that we have. This study actually evaluated hydroxychloroquine with chloroquine in this virus. They found that hydroxychloroquine is more potent than chloroquine, and they looked at free lung tissue concentrations in conjunction with the concentration that would inhibit the virus. They found that all of the doses they did look at did achieve a good concentration within the lungs and did effectively inhibit that virus in vitro. The minimum dose that they did use during this study was hydroxychloroquine 400 milligrams by mouth twice daily on day 1, and 200 milligrams by mouth twice daily on days 2 to 5, and that's why we use this regimen here. And the last study that I'd like to take a look at briefly is azithromycin inhibits influenza virus infection by interfering with the internalization. And so this is a basic science review paper. It really was looking at H1N1, so not coronaviruses at all, but it did shed some light on the fact that azithromycin may have some antiviral properties. It did not completely reveal the mechanism behind this, but did hint that azithromycin may be able to be used in a viral infection. So given some of this background, it was pretty clear that when this virus it came out and became a pandemic in the world, we needed something to treat it. And so the objective of this study was really to assess the clinical efficacy of using hydroxychloroquine in this SARS-CoV-2 infected patients. This study was funded by the French government under the Investments for the Future program. And again, as I mentioned, this was an open label, non-randomized phase 3 clinical trial. This study was conducted in Marseille, France at the Marseille Center. Patients at the Marseille Center were asked to be in this study, and then control patients were recruited from the Marseille Center, Nice, Avignon, and Briançon centers in the south of France, so not from the same location. The inclusion criteria for this study was that patients were over the age of 12 years old. They had informed consent, either themselves or their legal guardian, and they did have a PCR documented infection through a nasopharyngeal sample. Patients were excluded if they had an allergy to hydroxychloroquine or to chloroquine. If they had any contraindications to hydroxychloroquine, such as retinopathy. Retinopathy with hydroxychloroquine has shown to be irreversible, though this is much more common in patients that are taking really high doses and also for a longer duration of time, typically over a 5-year period. G6PD deficiency patients, they were worried for hemolytic anemia, so those patients were excluded, and then any patients with Q2 prolongation for worry about arrhythmia. Any breastfeeding or pregnant patients were also excluded from this study. There is just limited data in these patient populations and breastfeeding and pregnant populations, and so they wanted to leave those patients out of the study. For the methods of this study, the patients were recruited again from the Marseille Center and given the option to take the treatment drug. So if they refused or met the exclusion criteria, they actually served as controls. So as I mentioned, this is an open label design, so they did know whether they were taking the treatment drug or had the choice not to take anything at all. Once they were enrolled in the study, they were classified as either asymptomatic URTI, upper respiratory tract infection, or LRTI, lower. For an upper respiratory tract infection, it was simply symptoms of rhinitis or pharyngitis, and a lower respiratory tract infection were simply symptoms of pneumonia or bronchitis. The study arms in this article were hydroxychloroquine sulfate, 200 milligrams by mouth 3 times daily for 10 days versus the use of the control. Patients were seen at baseline for the enrollment and then initial data collection, and they were seen every day for 14 days. Again, this article that was released actually was released before the study was done, and so it really only had data from the first 6 days. And we should anticipate more data at the end of this study after they did finish the 14 days. Each patient did receive a daily clinical exam with a nasopharyngeal sample collected when possible. And then clinical data was used using standardized questionnaires. All patients did receive symptomatic treatment or antibiotics that were preventing a superimposed bacterial pneumonia, and this was really dependent on the clinical provider's clinical judgment. And so not every patient did receive antibiotics, but a few of them did receive antibiotics just for prophylaxis. The endpoints of this study were virological clearance at day 6, and then over the study period. We also wanted to look at clinical follow-up of body temperature, respiratory rate, length of hospital stay, mortality, and then the occurrence of side effects from this medication as well. In statistics, they anticipated a 50% efficacy rate with an 85% power and a type 1 error rate of 5%. They anticipated that a total of 48 patients would be necessary for statistical comparisons. Differences were evaluated by Pearson's chi-square or Fisher exact tests. These were appropriate for categorical variables, and for all the quantitative data, they evaluated these using student p-tests. Results of the study, so 42 patients total were included in the study, of which 36 had data through 6 days of follow-up. So they did lose a few of these patients throughout the study. 26 of the patients received the study drug, hydroxychloroquine, where 16 were in the control arm of the study. Now, it is interesting to mention the 6 patients that ended up being lost to follow-up all did receive hydroxychloroquine. So there were really only 20 patients in that treatment group as well. For baseline characteristics, I'd like to focus first on age. So the mean age for all patients was 45.1 years of age. But as you can see, there was a small difference. Hydroxychloroquine treated patients were a little bit older than the control patients. Though this was not statistically significant, I think it's something important to point out that there was a small difference in age here. Gender was pretty evenly distributed between both groups. And then the clinical status, so either asymptomatic URTI or LRTI, I think it is important to note here as well that most of our patients in this study were upper respiratory tract infection patients. And so they really weren't that severe patient that you're looking at that has those symptoms of pneumonia and is on a ventilator. These are patients really with a rhinitis, maybe a dry cough that went along with that as well. For our endpoints, this table shows the proportion of patients that have a virological cure by day in the study. And so as you go along, you can see that more patients were achieving that virological cure. At day 6 post-inclusion, so we have 6 out of 6 of our hydroxychloroquine and azithromycin combined treatment patients. 100% of them did achieve a virological cure. This is compared to 57.1% of the hydroxychloroquine treatment only patients and 12.5% of our control patients. Now, the study up until this point really hadn't mentioned the use of azithromycin, and that's because these patients, again, they were using azithromycin not for the COVID, but for a superimposed bacterial pneumonia prophylaxis at this point. And they just happened to notice at day 6 that the patients that were treated with both hydroxychloroquine and azithromycin, all 6 of them had achieved that virological cure. All right, so they also compared hydroxychloroquine to control without the use of azithromycin in there. So when comparing those two, 70% of the hydroxychloroquine achieved virologic cure, again compared to 12.5% of our control patients, and that was statistically significant. So the study limitations from the author thought that the sample size was a little bit small, which creates difficulties to extrapolate this data. And because this was a preliminary publication that was being reviewed and the study wasn't over yet, there's really limited information on the long-term follow-up for our patients. They also mentioned that 6 patients ended the study early. And I don't think patients leaving early necessarily is a study limitation, but given the size of the study, 6 patients was a fairly large portion of their study population. The authors concluded that the results are very promising, and all patients with SARS-CoV-2 infection should be treated with hydroxychloroquine and azithromycin for cure and to limit transmission. These preliminary results provide a possible treatment for this infection, and they also suggested further studies should be followed, especially for chemoprophylaxis in medical personnel. So some of the critiques that I pointed out, or that I noticed while I was reading through this, the first one, the design of the study was open label, and I know I had mentioned that. In an open label study, both the patients and the providers are aware of the treatment, or a lack thereof, really. and what they're receiving. So the unblinded nature of this study really predisposes a lot of this data to bias. And so there could be a lot of different bias simply from people knowing that they're not receiving treatment versus they are receiving treatment, to the actions of doctors because they knew as well. And so the fact that it's unblinded is kind of disappointing. The statistics of the study also indicated that for an 85% power calculation, they needed 24 patients in each arm of the study. The hydroxychloroquine group had 20 patients and the control group had 16. So unfortunately, they didn't meet their power calculation, which means a lot of their statistics just don't really prove anything statistically. Also in the supplemental material, I'd like to go to that real quick. Give me 1 second. Here it is. Okay, so this is their supplementary material. There are a few things I found when actually going through the supplementary that are a little bit off. And so the viral loads of these patients are going to be reported on the right-hand side of this graph over here. They are recorded as a PCR load, and that's how many times they had to run the PCR to detect the virus. So negative PCR load is identified as anything over 35 cycles because there really wasn't any virus in there. And just recorded as NEG, as you can see down here. All positive PCR patients have the positive PCR cycle count recorded, as you can see in these blue boxes. But I noticed that in the patients that did not receive hydroxychloroquine, so our control patients, they did not record a cycle count for all the positive patients. They simply recorded it as POS in a lot of these patients. This is pretty unfortunate in my opinion, because it makes it really difficult to compare the baseline viral loads between these patients when we don't have those cycle counts for a positive patient. And so I was able to compare them for a few of the study groups, but when looking at the treatment group versus the control group, we couldn't make any comparisons there. So to go off of that, I did compare the viral loads between patients that only received hydroxychloroquine right here and patients that did also receive azithromycin. There was some discrepancy there, but there was no statistical significance that was calculated. And so what I was able to find is that the hydroxychloroquine patients, the average cycle count was about 25.35, whereas the combination treatment had about 26.83 PCR counts. And so what this means, a lower count means that there is a higher viral load. And so the hydroxychloroquine treatment had about 1.5 values lower on the PCR count. What this means is hydroxychloroquine only, this group up here, did have a lower viral count than the patients that were treated with both hydroxychloroquine and azithromycin. And I'm not sure with a PCR how much more of the virus those patients would have, but it is curious that there was no statistical analysis that was done on these patients to see if their viral counts had any impact on the outcome of the study. So now we'll go back to our journal club real quick here. Okay, and then the last critique that I have is, as the authors mentioned themselves, they're because of the nature of these preliminary results, we don't have any long-term follow-up data on this. In the process of writing this paper, the authors actually did note that they showed 100% virological cure at day 6 when they had the combination of azithromycin and hydroxychloroquine. Actually, though, on day 8 post-inclusion, so these results were not in the results, one of those 6 patients that were treated with hydroxychloroquine and azithromycin did show up positive on virological PCR. And so if we go back to this supplemental real quick, you can also see here that patients that were treated negative, such as in this green box, just because they were negative one day does not mean they're going to be completely negative and have a virological clearance. They may come up positive the day after. And so only studying this group for 6 days and having such a small sample size really doesn't add to the statistical significance of this study, in my opinion. And so at this point, this is the end of our first study, the French study. In conclusion, I think that there is a lot of data that points towards the use of hydroxychloroquine and off of this study. That in conjunction with past studies mean that it may work in the future, but there do need to be future studies done. At this point, though, I'm not entirely convinced on the efficacy of azithromycin, just because the studies, the sample size for the azithromycin patients was so small, and there were some discrepancies in that virological data that was reported. And so this is the end of this journal club. If anybody does have any questions, again, feel free to use the group chat and I'll try and pay attention to that. If nobody has any immediate questions, I guess I'll get started here in maybe a minute. On the second journal club, again, this article that I'm going to get started on is the efficacy of hydroxychloroquine. It looks at clinical outcomes, and this one was published on Monday. All right, and I'm not seeing any questions yet, so we'll go ahead and get started. And then if any questions do come up, once again, feel free to use the group chat and I'd be happy to answer those as we go along through the journal as well. So I'm not going to go through the background for this journal here because it's really the same as the previous journal that we just had. The objective of this, after that last study came out suggesting hydroxychloroquine may be beneficial in the treatment of COVID patients, this study actually did a follow-up survey and found that none of their 80 SLE or lupus erythematosus patients that were taking long-term hydroxychloroquine had actually been infected with SARS-CoV-2. And then they did another retrospective review and found that none of the 178 patients that they had at their hospital had received hydroxychloroquine treatment before their admission. So they looked at this and data from the other studies, and they decided they wanted to design a study to investigate the efficacy of hydroxychloroquine more thoroughly in patients with COVID-19. So this study was funded from the Epidemiological Study of COVID-19 Pneumonia to Science and Technology Department and took place in Hubei, China, or Wuhan, China. This was a single-center, double-blind, randomized clinical trial, again, taking place at the Wuhan Institute, Renmin Hospital, and Wuhan University. Patients were enrolled in the study between February 4th and February 28th of this year, and again, from that single hospital. Patients were included if they were over or equal to the age of 18 years old. They had a PCR positive for SARS-CoV-2, a chest CT showing pneumonia. They were not very specific on that, so that is fairly subjective. And then a PaO2 FiO2 ratio over 300 milligrams per milligrams of mercury. This indicates really a mild disease. It can be used to assess ARDS in patients. And so a PaO2 FiO2 ratio over 300 is going to point out that this is a mild disease here. And I just got a message real quick. Let me read that very fast. And I believe everybody can see that from that message from Melinda as well. The last inclusion criteria for this study was that these patients did have to be willing to be randomized because this was a randomized study. This study did have a few more subjects in the exclusion criteria. Severe patients or critically ill patients were excluded from the study. Any patients with retinopathy, as we discussed for the previous study, conduction blocker arrhythmias for QT prolongation, pregnant or breastfeeding patients were all excluded. This study also excluded patients with severe liver disease and severe renal failure and renal replacement therapy. For this one, I'm not entirely sure why they excluded these patients. There is no renal or hepatic dose adjustment for hydroxychloroquine. My best guess would be they were using this as a marker of severe organ damage or just of disease severity. And then any patients that had a possibility of transfer within 72 hours or received any other study drug was excluded as well. So in this study, again, this is a pretty recent study and has not been peer reviewed, so there isn't much information. The methods they treated with hydroxychloroquine, 200 milligrams by mouth twice daily for 5 days, plus a standard treatment. And this was in comparison to the standard treatment alone. What is the standard treatment? So in the study, they recorded this as oxygen therapy, antiviral, and antibiotic agents, but they didn't clarify what those were. So unfortunately, I don't have any data to say what were those antiviral agents. Immunoglobulin, and then with or without the use of corticosteroids was the standard treatment. The endpoints they were looking for were the time to clinical recovery, which was the return of normal body temperature and cough relief that was maintained for more than 72 hours. The normalization criteria is below, but that's pretty specific information. It goes over the temperatures they were looking for and what they were looking for in the subjective cough evaluation. Statistical analyses, unfortunately, this section was pretty slim in the study as well. It was only about one sentence, but data was reported as means in the study, and t-tests or chi-square tests were used to compare the differences between groups. The t-tests were going to be used for continuous data, and the chi-square test for discrete data in the study. In the study, 142 patients were admitted to the hospital between these dates. 80 of those patients did meet exclusion criteria, though, and weren't included. So they had a total of 62 patients, which luckily were randomized evenly with 31 patients in each arm of the study. The mean age of the patients was 44.7 years old. For sex, we had 54.9% as female. The first table that we have here and our primary endpoints is going to look at the time to clinical cure of fever and cough. And if we look at the second here, I wonder if I can highlight. So if we look at these two areas here, in our control arm for fever and cough, the time to clinical resolution was about 3.2, 3.1 days. In the hydroxychloroquine group, we had 2.2 and 2.0 days. So they reduced that time until clinical cure by about 1 day. And the p-values for these were statistically significant. 22 of these patients versus 17 in the fever group and 15 in the cough group did have a fever or cough at day 0. And so there were differences in the patients that were in each arm of the study and how many patients actually had the fever, but they were reporting these as means, and so they did their best to kind of equalize for that. In our second chart here for the results, we have the absorption of pneumonia on a CT chest scan. And so they recorded this data as being an exacerbation or worsening of the pneumonia, an unchanged in the pneumonia, or an improvement in the pneumonia, either moderate, significant, or significant. And so if we look here at the total improvement, so in our control group, we had about 54.8% of our patients that did have an improvement in the pneumonia. And in the hydroxychloroquine group, we had about 80.6% of those patients received or did have some improvement of the pneumonia. This p-value was statistically significant, though it is approaching that 0.05. And so it's it is significant, but again, it's getting closer towards that not significance. And then they did look at safety endpoints. One patient did develop a rash and one developed a headache as well. For authors' study limitations they identified for the study, they only identified that this was a small number of patients in their study. They concluded that even though it was small in the sample size, the efficacy of hydroxychloroquine for the treatment of SARS-CoV is partially confirmed by this study. And even though it isn't entirely confirmed because there's not a better option, it would be prudent to start everybody on hydroxychloroquine. And then further studies are needed, as was the conclusion of the last study as well. So some of my critiques for this study. The first one is actually something I didn't notice myself, but upon reviewing some literature, and there was actually something that was a statistical review that was published this morning about this by YAP that I want to pull up. There was a little bit of a difference in the study protocol that when this was submitted to the Chinese clinical trial program versus what was actually reported. And so I'm going to pull up this here. This is actually the Chinese clinical trial registry. And so it's the study that we are looking at currently. The one thing I noticed is in these interventions here, there are actually 3 intervention groups when they submitted this protocol to the clinical registry site. And so there are 3 here, but when you look back at our journal club, there were only 2 groups, the treatment and then the standard care group. And so I don't know what happened to that 3rd group. And so I know there were some differences or discrepancies in their treatment protocol once that was submitted. In the study, at a different point after I realized this, the authors also clarified that the randomization of patients are going to be stratified by each site. But this was a single center study. And so because there are some differences in that protocol, it makes me curious as to whether that was just a translation error from a Chinese study or where the patients actually were coming from. There were baseline characteristics that were largely unreported in this study. And so we have data here from the absorption of pneumonia on their CT chest scan after the study, but we don't have what those scans looked like to begin with. And so this is also a pretty subjective thing. evaluating this through an exacerbation, unchanged, or improvement, but they don't ever qualify what equals an exacerbation or what equals an improvement. It's just subjective readings of the CT scan that allow them to come up with that data. The study also, as I mentioned, didn't have a huge section on their statistics, so I actually ran my own power calculation for the study. The statistics section, when it's given an alpha of 5% and then a power of 80%, they would anticipate a sample size of 49 patients in each arm to be required to accurately show that 81% improvement in pneumonia versus that 55% improvement. And so unfortunately, with the size of their study, they had 31 patients in each arm. They didn't meet the power calculation that I had put forward for them. Again, they may have done their own power calculation earlier on in the study, but that was not reported at this time. So in conclusion, I think with these two articles, there is evidence pointing towards the use of hydroxychloroquine, though we do need future studies. And when so many studies keep coming out that are underpowered, it's hard to find with any certainty, to say with any certainty that that is going to work in this patient population. So I do think there need to be more studies, randomized blinded studies in the future coming out for hydroxychloroquine. At this point, I'm not convinced on azithromycin, though it may have some use. It does require longer studies and with a larger sample size for that patient population as well. And at this point, here are my references for the journal club. This is recorded, so we'll try and figure out a way to send this to everybody if anybody had to miss or leave early. If anyone does have any questions, feel free to use the Zoom group chat. I could unmute everybody, but if I unmute all 11 people at once, I think it might get a little crazy. But feel free to use the chat if you have any questions. And I'll sit here for a few minutes and make sure there's no other questions before we kind of conclude the journal club.
If you have a question, this is Amanda. You have the power to unmute yourself if you want to also.
Oh, I hear something, but it was very quiet.
Oh, sorry. Can you hear me?
I can now.
Okay. It's Amanda. I'm just playing with Zoom too, and I found that if you go to participants, you have the ability to unmute yourself. So in case someone does have a question, you can do it that way too.
That is perfect.
I don't actually have a question.
I'll talk about it. I also saw that Melinda made a comment, and just in case anybody's on the phone and can't see the group chat, I'll just read it out loud so everybody can hear it. So Tyler is correct to point out the difference in viral load between hydroxychloroquine alone and combination in this group. One of the major limitations of this study, and this is the French study, the first study we're looking at, is the non-randomization of the study. The title is catchy, but the data does not support the title. And I'll repeat Amanda's comment real quick. For everybody that is listening, if you pull up the participant list, let's see, I believe that's on the top part of your screen. You can click on Manage Participants. There is a little video and a speaker icon next to everybody's name. I believe you can unmute and mute yourself. And so if anybody does have any questions, feel free to unmute yourself and you can ask questions that way as well. And if any questions do come up after the fact too, feel free to email me. My email is tyler.maxwell@stonybrookmedicine.edu. And I think that it automatically sends an email with my email as well to participants in this chat. And I'd be happy to answer any questions after as well if they come up. So Melinda just asked, how many patients progressed to mechanical ventilation in the second paper? So in the second paper, let me move back over here. They had an exacerbation. In the total amount of patients, we had 11 patients that their pneumonia got worse. Unfortunately, they didn't define what that worsening of pneumonia was, and so they didn't mention how many of those patients specifically needed to be ventilated. At least that I remember. But there were 11 patients that they just subjectively said that it had gotten worse. Let me show the baseline character. So for the baseline characteristic, I can go back to what they had shown, but there is not much they reported. That was one of the main critiques that I had on this study, is that there are a lot of baseline characteristics that we just don't know. In the second study, we don't know what their chest X-ray or chest CT scan looked like at baseline. We don't know a lot of the information as far as just the baseline kind of demographics of this group as well. Yeah, let's go back. And so this is pretty much everything that they had showed for baseline characteristics, which really aren't baseline characteristics. It's the evaluation of fever and cough. The only statistics that they had reported for baseline were their mean age and the percentage of patients that were female. For how sick they were at baseline, I may be confusing this with the previous study as well. They were not severely ill, and so actually that was one of the exclusion criteria, that if they were severe or critically ill, they were excluded from the trial. And so they didn't say necessarily like what their O2 requirements were, but they did clarify that these patients were not going to be the ones that were severe or critically ill. They're not the ones that had ARDS, and so they had a fairly good PaO2 to FiO2 ratio when they did come in for presentation. And then Melinda just asked, what are the positive clinical outcomes? So the positive clinical outcomes that they were looking at are the time to resolution of fever and cough. And that is reported in the number of days it took until we had that clinical resolution for hydroxychloroquine versus the control groups. They found that with hydroxychloroquine, patients reduce their time to clinical response to the virus by about 1 day, and that was statistically significant. But unfortunately, this was underpowered as an entire study as well. And Melinda just asked, are these hospitalized patients? These were hospitalized patients. Yes. They were all recruited from the Wuhan University Hospital in Wuhan, China. And Melinda just responded, it's unfortunate they did not give us a sense of the progression of the disease. And I completely agree. They really, the information that was in that study, and again, it hasn't been peer reviewed, so it may change over time, but the information they've reported so far is somewhat lacking in a sense, and it doesn't give us, they don't give us a sense of the progression of the disease. They don't give us a lot of their definitions for what an unchanged or improved pneumonia was. And it would have been nice to have a lot of those definitions as we kind of move along with the study. And Melinda responded for those on the phone again that our observation is that a big portion of our patients are going on to being intubated. And I tried to find some data on that for the background as well. This study, specifically, neither of these actually did evaluate ventilated patients. They stuck to patients for hydroxychloroquine and that combination plus or minus azithromycin that were mildly ill. And so a lot of those patients, remember in the first study, were upper respiratory tract infection. In this study, they excluded patients that were severely sick. I tried to see what maybe the percentage of hospitalization and mechanical ventilation was, but I haven't found a whole lot of success finding a solid number for that. What is their definition of severe disease? For control qualified for what? I'm not sure. I'm not sure if I understand the question. The definition of severe disease. Or for the exclusion criteria. They did not define that. That was just part of their, at least in what they have published at this point, they have not defined what the definition exactly is for severe critical illness. I'm assuming that any patients in the ICU or ventilated would fall under that category, but at this point they have not talked about what those definitions were. For control qualified. Controls. The severe disease, I think that in the study it mentioned that there were 4 controls that did progress to severe disease, but those patients again, I don't think that they ever defined what severe disease is, specifically whether that's like a location in the hospital. I'm not sure if they had ever defined that I've seen. But I can try and look into that and see if maybe there was something else in the study I'd missed that gives us a more clear definition. There's a comment about no death. They did not report any death during the study. They did clarify in the study that they, by making that part of their exclusion criteria, they were treating mild disease. They had Melinda was asking about the adverse events that were reported in the second study. They had not reported any. Or I'm sorry, there were 2 actually. I confused the 2 studies. So there's 1 patient that did develop a rash, and 1 patient that developed a headache a few days into the study on hydroxychloroquine. Those were the only 2 adverse events that they reported with hydroxychloroquine in this study. All right, thank you. And if anybody else has any questions, I can answer those too. All right, I'll give it another minute. See if any last minute questions pop up. All right, I'm not sure that there are any other questions at this point. Again, if any questions do come up, feel free to send me an email, and I'd be happy to get you any more information or anything like that if things come up later on down the road. And then for anybody that did have to miss this once more, we did record this session, and so we'll be finding out how we're going to distribute that shortly here, and we'll try and get that, make that available to everyone as well. All right, thank you very much all for attending this journal club and kind of trying to learn a little more about the studies coming out on hydroxychloroquine plus or minus azithromycin for COVID-19 patients. Again, once again, if anybody does have any questions, feel free to email me and I'll try and get back to you as soon as I can. Thank you and have a great weekend. Is there a CE code?